So as the discussions in Congress go on for the legislation to provide a fix to the SGR, and as they include discussions around the patient-centered medical home, again, the Academy is paying close attention and trying to influence that development there in Congress and also within CMS, because they also have a track going on, as mentioned, to develop standards for chronic care management services for 2015, that whatever standards are developed, again, recognize your patient population and are applicable to the population and to the home care medicine practices. As mentioned, from a legislative perspective, there would be a 5% bonus paid to practices on their fee schedule payments effective 2018 forward. The care management services themselves at its code level would be paid 2015. The bonus system would come into place 2018 forward. Again, this is under one proposal under consideration in Congress. Again, that would includes the designation as a patient-centered medical home or similar approved by the Secretary of the Department of Health and Human Services. And again, that's where we want to provide as much opportunity and reflection for Academy members as possible. From a Medicare regulatory perspective, again, that track is going on. And you may receive information and be asked to participate in surveys about these codes over the next weeks. And the Academy is involved in advocacy on your behalf regarding these codes and those standards. I also look at the standards of the patient-centered medical home as a way of, again, organizing practice, whether it's called patient-centered medical home or there are similar standards that, if they are adopted by Congress, approved by Congress and signed into law, or if Medicare establishes their own standards this year, as we expect them to do through the rulemaking process, I would look at those and the elements that we described in terms of the plan of care and also these patient-centered medical home standards as a way of organizing practice relationships. Who are those partners and vendors who can support those services around access to care, continuity? These could be call groups. These could be called answering services, recruitment, your policies and procedures, the EHR you use. What is the support of the EHR vendor or your in-house provision in terms of the plan of care, the throughput, the templates that you use, the technology that's used, and again, the self-care support resources and the coordination. So I would look at each of these elements and see who is in your community, who are you partnering with, who are you purchasing services from, who can you get engaged with to support each of these elements and to facilitate your successful adoption of those requirements and to help you operate and to grow your practice. And they would also be providing expertise and assistance and resources and best practices in each of these areas as well as part of the exchange of the relationship with your practice. You would also notice, and we do hope that you all attend the annual meeting in Orlando in mid-May, that many of the partners that will be on site exhibiting and describing their services to you match up with these requirements as well. And so what we're finding is, from the Academy perspective, is that the interest in your services as the field grows and as there's this recognition of standards development around the Medicare program, that these partners and vendors and service providers are increasingly making themselves available to the Academy and interested in getting to know you and supporting your services, the field of home care medicine, and the Academy as the field grows and as your services grow and the population in need grows. So who accredits presently the designation of what's called the patient-centered medical home that we just reviewed? There's 4 organizations that explain the accreditation, because Medicare currently does not deem or do this. The organizations that currently accredit practices for patient-centered medical home status are the National Committee for Quality Assurance, or NCQA, that has about 3/4 of the accreditation, that explains about 3/4 of the accreditation that occurs, the Joint Commission, the Accreditation Association for Ambulatory Healthcare, and then finally explaining a small percentage of accreditation for patient-centered medical home status is URAC. In surveys by the Medical Group Management Association, there is a understanding that certain expenses increase, as we mentioned about in terms of building the structure and infrastructure and support and services to satisfy the patient-centered medical home standards. And some of those are listed here. The information technology expenses increase, medical equipment, medical supply expenses. Again, much of this is oriented around office-based practices, clinical facility expenses, and then on the non-material basis, physician costs, increases non-physician providers, care coordinators, etc., registered nurses, LPNs, and medical assistants. So takeaways regarding the plan of care. Would organize to support the plan of care-based approach to services, and as we saw, that likely explains the majority of your services and revenue. There are new codes and practice standards being established that describe and incorporate a description or requirement for a plan of care. The Academy provides advocacy on the codes and regulations. We're advocating for payment for services you render both face-to-face and non-face-to-face, and this would be personally and through practice staff, such as the time and efforts of your practice staff that is not face-to-face with your patients that ties into coordinating care would be documentable and countable toward payment for these services. And again, that's what's being reviewed and surveyed this year. We advocate for a focus on the high-cost multi-morbid population, and that to include home care medicine services, your services, as a requirement to render service and to receive payment. In other words, we believe that standards that develop for support of these services should recognize that home care medicine services are a key component, and that if there are standards to approve practices to be paid, there should be an incorporation or a requirement for house calls to be part of that practice as well. And then practice standards should provide and support home care medicine and not include requirements that are not relevant to the care of the population nor supported by evidence. Along this way, we have a literature research search going underway to review standards and to see if there is literature and evidence out there that ties in the standards with evidence of results touching on care, cost, satisfaction, utilization. We hope to have those results over the next few weeks and months, and that is to incorporate into our communication with Congress, with CMS, and others around the standards development. So we have that underway, and we also think that you should prepare this year for the codes, services, and payment systems that are described, that are evolving and scheduled to come into effect as early as 2015. Develop practice relationships that support plan of care-based services, and again, develop Academy resources and describe those for you. They include the booklets, the field guide, e-communications, the Academy website, There'll be multiple presentations at the annual meeting this year. It'll be an outstanding meeting in mid-May, and again, hope to see you all there. That'll discuss many of the topics that are covered on the webinar today. The advocacy, the Academy and you will be included in surveys of these codes. We participate in multi-specialty groups to influence CMS and others. The Academy also interacts directly with Congress and CMS. And we are also developing a standards development steering committee to develop, based on the literature search and consensus development, what recommendations to provide to CMS and to Congress. Later this year, there'll be a second part of this webinar. And as mentioned, I'll post literature around each of those elements of the elements of the plan of care for your resource and use. And now I'd like to take your questions. We will post the, we'll also post responses to any of the questions, including how to bill and code for the annual wellness visit. The annual wellness visit can be provided as a standalone service and can also be rendered in conjunction with a medically necessary evaluation and management service. Let me get back to the screen with the questions. We'll also post these slides over the next week. A question came in, does the Academy have resources or talking points to encourage hospitals to partner for transitional care? We do. We have some materials that were garnered through a meeting at an annual meeting of the Academy a couple of years ago, what Academy members are doing around the country. We have that group of materials and some supporting talking points available, and we'll post those. And if you want to email me at gary.swartz@aahcm.org, I can also respond to the individual who answered this, who asked this question. But those materials about how to have discussions around transitional care management with services, with hospitals or other organizations are available. Also, later this year, we're going to develop a standalone webinar on how to develop those relationships, present the case for how home care medicine and care your services to hospitals, health plans, and other parties. And that'll be a distinct webinar later this year. Also, those services and discussions will also be described and presented at the annual meeting this year. Again, I will collate those resources that we did develop around transitional care and hospital relationships and put out in the e-news and on the listserv that where they're available on the Academy website. Someone wrote in more from a describing their services rather than from a question perspective. It appears that they're providing services in adult family homes in the state of Washington. Oh, actually, and the question is they've been asked to provide nurse delegation service that include developing care plans, assessing patient function, and reviewing medications, and that the patients pay out of pocket. As we know, some of the services, such as this, developing care plans, assessing patient function, and reviewing medications, if the services are not incorporated in the evaluation and management services and under the coverage and payment policies of Medicare presently, one alternative to that is to have the advanced beneficiary notice in place and to bill and collect from patients or the families directly. Another alternative would be to make arrangements with those organizations, and some Academy members have, where they are providing services and being paid by the group homes and ownership of those group homes themselves as a means for the group homes to differentiate themselves in the marketplace. So again, that shows some of the recognition of your services and packaging and payment for the services that is occurring, that is outside of the Medicare fee schedule, but is also increasingly being recognized by Medicare to incorporate into the Medicare program. In this situation, if there is a question there about how to do that, again, the recommendation is to either develop a standalone contractual relationship with the group home, a business relationship to provide those services, or alternatively, to provide those services to the beneficiaries and I would just want to have that financial sort of informed financial consent in place and documented with an advanced beneficiary notice. And we do have that information on the sites. And again, if I can send that information out to where that's located, the Medicare Advanced Beneficiary Notice forms. Again, there was a question about the annual wellness visit and billing with an evaluation and management code. That can be, since it seems to be a question that's come up a bit, so I did introduce the annual wellness visit situation because of the plan and care inclusion. I will include the Medicare references to that in the next electronic e-news, and then also in the listserv so that everybody sees the response. And basically what I'll post is the Medicare MedLearn materials on describing that service and how that's done. A broader question has come up about patient-centered medical home model when there are services that can be rendered in assisted living facilities. The patient-centered medical home shouldn't, I'm going to try one track with the question. The patient-centered medical home shouldn't be considered a physical location itself for care, but rather as the incorporation of those various standards of practice in delivering and organizing care. And developing those standards and those resources and approach to care could be in effect regardless of where one provides services, whether that's in a home environment, their office environment, or an assisted living facility. Again, one of the impediments to the development, further development, or the speed of development of patient-centered medical home models has been, again, the lack of direct payment to recognize the cost of developing those services and structures. Again, but it could be in place for primary care practices regardless of the setting in which you deliver services. The services that come up, just as a general overview, there was a question about CPO codes, transitional care management, and this would be the case for the chronic care management services next year. Since there is so much overlap of the service and the care coordination aspects, those services, the codes, do in effect become mutually exclusive. As we know from the transitional care management services, they cannot be billed in the same month that CPO is billed, and it is also envisioned that with the chronic care management services that there would be decisions to make or there'd be exclusions. Either CPO would be billed or the chronic care management services, et cetera. So Medicare is aware that there is overlap or duplication of services, or that basically that gets back to the care, the plan of care, that so much is tied to that, and that is similar across these code descriptions. And each practice itself would have to evaluate which approach to take. If you have a lot of patients that you have the evaluation and management services, and you're also providing CPO, that may be practice advantageous to take that approach versus using the transitional care management services, which also require hospital discharge. The chronic care management services themselves that are under development for next year would not require a hospital discharge necessarily, but would have other characteristics, including multiple chronic conditions, the threat of decline or hospitalization of the patient, et cetera, if they weren't receiving those chronic care management services. So again, those types of descriptions are being built in or developed under development for those services under consideration for next year. And again, each practice would have to evaluate its clinical throughput, its patient population, the type of patients it's seeing, relationships with home health agencies, what is the source of your patient population, to determine, again, what is most advantageous, the best care for your patients, and also that makes most sense for the practice to provide and receive payment. The documentation, and I think this may relate to the point at the beginning of the presentation about a house call in lieu of an office visit. Does that medical necessity need to be documented each visit, or would that be sort of a one-time only as a matter of record in the patient's chart? And that is that requirement is for each visit requires that documentation of the medical justification for that house call in lieu of an office visit. A question came in about whether a patient on a patient level would understand that they're receiving care in a practice designated as a patient-centered medical home or not. And as mentioned, the designation, the patient-centered medical home standards were established by a primary care consortium in the late 2000s. Various organizations, there's 4 that were described, have developed certification protocols and survey processes, et cetera. And practices then elect to be evaluated by one of those organizations to receive that designation, and there's cost involved, there's documentation. For some, for example, there's a submission of documentation electronically about the practice, and then follow-up by surveyors to assess the practice and to document that those practices and processes are in place in order to receive the designation. Then when a practice receives that designation, they then use it as a practice development or marketing feature to take to health plans, hospitals, et cetera. So that is a very formal and a structured process. Do want to describe that. So that would be done at a practice level with a health plan. And as mentioned in the New York Times article this week, sometimes patients know that they are receiving in a care in a practice that's been designated as a patient-centered medical home. Sometimes they may not. They could be receiving additional notices of follow-up, and this again is maybe more relevant to office-based practices, of the need to return for visits or follow-up regarding a certain chronic condition, et cetera, that would be part of the CQI process to meet the requirements for that population by that practice. Where it ties into codes for next year, the codes that are under development for chronic care management services by Medicare are considered by Congress for payment for next year may include a requirement that the beneficiary is noticed that they are going to receive these chronic care management services and agrees to receive those services. Again, this is going to be documented, and that would then need to be documented in the chart, and there has been discussion by groups working with Medicare about whether that would be done each month or each year, et cetera. But the idea is that beyond evaluation and management services, that the patient understands that they are receiving chronic care management services. And the reason that that's important is because these services, again, are to pay for your non-face-to-face services. So a beneficiary, a patient, and you can think of it just as ourselves as consumers or et cetera, or family members or caregivers, that someone could be receiving a bill, a claim, or the responsibility for the 20% of the Medicare payment, and not be aware that services were rendered because we may not see them being rendered, from that face-to-face perspective. So, in the development of these codes, there is description of the requirement for beneficiary, notice and acknowledgement. So we will do more on that, again, as we see the development of these codes, of the chronic care management services and the standards during the course of this year, and certainly provide you with that information and the description of those requirements. Okay, we are about at the end of the hour. I want to thank you for your attendance and interest this afternoon, and for the questions. As mentioned, I'll post that information about the annual wellness visit, and again, we will keep you informed of these developments on these codes and on the legislation affecting the sustainable growth rate services, and of course your services in the field as that develops over the next weeks and months. Again, thank you, and we would look forward to seeing you in May in Orlando. Have a good afternoon.